Okay, picture this. You're just going about your day, out for a jog, grabbing a coffee, whatever it is, and then bam, someone near you just collapses.
It's a scenario most of us don't really want to think about.
Yeah, scary for sure. But this could be sudden cardiac death, and it's responsible for, get this, half of all deaths from cardiovascular disease.
That's a huge number, and it really highlights how important it is to understand this often silent killer.
That's what we're doing today, diving deep into this. We'll uncover those warning signs, the different causes, and most importantly, what can we even do to protect ourselves and our loved ones?
I really want to thank the London HeartbeatsZ Academy. They offer over 150 popular courses on this, and their support really made this deep dive possible.
Absolutely. And don't forget, check out their website and subscribe to their social media for more insights. Facebook, Instagram, Spotify, and YouTube for free regular updates. Now let's jump in, shall we?
Let's do it.
So, I think sometimes the terminology surrounding all this gets a little confusing. We hear things like cardiac arrest and sudden death. What do these even mean?
Yeah, it's important to clarify. When we talk about out-of-hospital cardiac arrest, or OHCA, what we're really getting at is anytime someone's heart just stops beating unexpectedly, when they're not at a hospital.
Okay, so OHE is like the general term. Then we get more specific.
Exactly. Sudden death then means death occurs within an hour of symptoms starting. Like, boom, it's sudden.
So like someone's healthy 1 minute and then...
Exactly, gone the next.
Yeah.
And then we have sudden cardiac death, or SCD. This is when the cause of that sudden death is related to a heart problem.
Okay, so it's sudden death from a heart issue, and that's what accounts for so many deaths, right?
Yeah, unfortunately, SCD is responsible for half of all cardiovascular disease deaths. It's pretty startling.
It is. So let's break down those heart problems. What causes SCD?
All right, well, one you've probably heard of is atherosclerotic cardiovascular disease, or ASCVD.
Right, isn't that the one with the plaque buildup in the arteries?
Bingo. That buildup restricts blood flow to the heart, and you can end up with heart attacks, which, you guessed it, can lead to SCD.
It's almost like a plumbing problem, right? Like a clog of the pipes.
That's a great way to put it. And then you have things like inherited conditions, arrhythmias, cardiomyopathies. Those can up the risk of SCD, too.
So your genes can really play a role here.
Oh, absolutely. With inherited arrhythmias, someone's kind of predisposed to irregular heart rhythms, which can be very dangerous. And cardiomyopathies, well, those are inherited diseases of the actual heart muscle itself, so makes the heart more vulnerable.
Really highlights how important family history is.
I completely agree. But it's not just genes and plaque buildup we have to worry about. There are other structural issues with the heart, too, like valvular diseases where the heart valves just aren't functioning properly, or myocarditis, that's inflammation of the heart muscle.
So many different things can go wrong.
It really is. And then certain external factors can also increase the risk. Vasculitis, that's the inflammation of blood vessels, and some drug toxicities can also impact the heart. Even something like a coronary artery spasm, where the arteries temporarily tighten, can be deadly.
It's scary how many things can lead to this.
Right. And of course, any physical trauma to the heart, we call that cardiac trauma, can also lead to SCD.
So much to consider. Are there any, less obvious causes people might not know about?
Oh, for sure. For example, cardiac tamponade. This is when fluid builds up around the heart and puts pressure on it so it can't pump effectively.
Oh, wow. That sounds dangerous.
It is. Think of it like the heart's getting squeezed, preventing it from filling up with blood. Then there's aortic dissection, which is a tear in the aorta, the main artery carrying blood out of the heart. And a ruptured aortic aneurysm. That's when a weakened section of the aorta bursts. All sudden, all catastrophic.
So many possibilities. It's definitely not just one straightforward thing.
It's really complex, But, there are even patterns in when these events are more likely to happen, which is fascinating.
Oh, this is getting interesting. What kind of patterns?
Well, for one, research shows there's a peak between 6 a.m. and noon.
Really? Right when people are starting their day. Why is that?
It's still not fully understood, but there are theories, hormonal changes, blood pressure changes, heart rate stuff in the morning. We also see a surge in ventricular fibrillation or VF-induced OHCAs, specifically in the late afternoon.
VF, that's like a super dangerous irregular heartbeat, right?
Yep, a chaotic rhythm that can quickly lead to cardiac arrest. And for some reason, Mondays seem to be a particularly bad day for all sorts of SCD events.
The Monday effect. Is it just the stress of going back to work?
Could be, but the exact reason's a bit of a mystery. The point is, understanding these patterns could help us develop better preventative strategies.
It's crazy how much we still don't know about the heart. But this is all helpful info. But it also makes me wonder, are there any warning signs that someone could be at risk?
That's the million-dollar question, and the answer is yes, there are some red flags to watch out for. For instance, never, ever ignore unexplained chest pain, discomfort, or tightness. Always get it checked out.
Even if it doesn't feel like a classic heart attack.
Exactly. Better safe than sorry. And excessive shortness of breath, fatigue, palpitations with exercise, that kind of thing, those could be signs of a heart condition too.
So if your body's telling you something's off, especially during activity, listen to it.
Exactly. A couple of other things too. A history of a heart murmur, that abnormal sound doctors hear, or high blood pressure can also be potential warning signs.
Those regular doctor visits are super important then.
You bet. Catching those early signs is key. Believe it or not, even sensorineural deafness can be a red flag.
Wait, what? How is deafness related?
It's less common, but it can be a sign of long QT syndrome, or LQTS, which is an inherited heart rhythm disorder.
Wow, really shows how diverse these signs can be.
You got it. It's all about connecting the dots. Other things to think about. Being restricted from sports in the past could indicate a previous heart issue, or any cardiac testing your doctor might have ordered before.
Knowing your medical history is so important.
Couldn't agree more. And of course, family history matters. If there's a history of heart disease in the family, especially early heart disease, that definitely increases your risk.
Makes sense. So let's say someone does have some of these warning signs, or they're worried about their risk. What kind of tests can doctors do to, get a better look at what's going on?
Well, there are a few tools in the toolbox. One of the most common is the echocardiogram, or echo.
That's the one with the gel and the wand, right?
That's the one. It uses sound waves to create a moving picture of the heart so doctors can really see how it's working.
That's pretty amazing. And isn't there something called a stress echocardiogram too?
Yep, that's right. Similar to the regular echo, but this time the patient is exercising, or they might give them medication to mimic the effects of exercise. This helps see how the heart reacts under stress.
So they're basically giving the heart a workout to see how it handles it.
Exactly. Then we have the coronary angiogram, or CAG. This one is a bit more invasive, but it gives a lot of detail.
How does that one work?
So they insert a thin tube into an artery, usually in the groin or the arm, and guide it up to the heart. Then they inject a special dye, and this allows them to see the coronary arteries, those blood vessels that supply the heart muscle, and check for any blockages.
Like an X-ray, but for the blood vessels of the heart.
You got it. Doctors can see if there are any areas where blood flow is restricted.
So those are some tests that let doctors see the heart. What about ones that focus on the electrical activity?
Well, for that we have the electrophysiology study, or EPS, and mapping. This is where catheters, kind of like in a coronary angiogram, are threaded through the blood vessels to the heart, but instead of dye, they record the electrical activity.
So it's like getting an electrical blueprint of the heart.
Exactly. Helps identify any abnormalities in heart rhythm or conduction.
Wow, the things they can do these days are incredible.
And of course, we can't forget about genetic testing. It's getting more and more important in cardiology.
Makes sense, given what we talked about with inherited condition.
Right. Genetic testing can pinpoint those conditions that could lead to SCD, and that helps with prevention and treatment.
Like getting a peek into the future of your heart health.
You could say that. And finally, in some cases, a myocardial biopsy might be necessary.
What's that one like?
Basically, they take a small sample of heart muscle tissue and examine it under a microscope, looking for signs of disease.
Wow, so many tests. It's amazing that doctors have all these tools to diagnose these complex conditions.
They do, and they pick the right tests based on the individual patient and their symptoms. Really tailored approach. Sometimes genetic testing is particularly important, like with arrhythmogenic right ventricular cardiomyopathy.
Now that's a mouthful. What is that exactly?
Well, it's an inherited condition that affects the right ventricle of the heart, one of the heart's chambers, and it can significantly increase the risk of SCD.
So in those cases, genetic testing really can be a game changer for treatment.
Absolutely. And there are others like Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, or CPVT, and of course long QT syndrome. Genetic testing can be super helpful in those.
It seems like genetic testing is becoming more and more important in this field.
It is, and it's for good reason. It's giving us this deeper understanding of how our genes can influence our heart health.
That's amazing. So we've got a handle on the causes and how to diagnose potential problems. Let's talk treatment. How can doctors prevent SCD, especially in those who are at high risk?
Well, one of the most effective weapons we have is a class of medications called beta blockers.
I've heard of those.
Yeah.
Aren't they used for high blood pressure?
You're right, but they also do wonders for protecting the heart. For instance, in patients who have had a previous heart attack and have what we call left ventricular systolic dysfunction.
Hold on, what's that now?
Basically, it means the left ventricle, the main pumping chamber, isn't pumping as well as it should. Beta blockers can help improve that function.
So they're giving the heart a little boost.
You could say that. And in people with long QT syndrome and CPVT, which we talked about earlier, beta blockers can help regulate heart rhythm and reduce the risk of those dangerous arrhythmias.
So beta blockers are kind of a jack of all trades when it comes to heart protection.
You could say that. They have a wide range of uses in cardiology, and they've proven to be very effective in preventing SCD.
Good to know. Are there any other preventative measures, particularly for folks with cardiomyopathy?
Yes. For patients with cardiomyopathy and reduced ejection fraction, that means the heart's pumping power is weakened. There are a few things we can do, beta blockers, of course, but also mineralocorticoid receptor antagonists. Those help manage fluid balance and reduce strain on the heart.
So they're making the heart's job a bit easier.
Exactly. We also have ACE inhibitors and ARBs, which lower blood pressure and protect the heart from further damage.
It's often a multi-pronged approach then.
It really is. And we can also use angiotensin receptor neprilysin inhibitors, or ARNIs. Those are good for treating heart failure and reducing the workload on the heart.
It seems like there's a lot of research being done to find different ways to help the heart.
Absolutely. And there are even more options, like SGLT2 inhibitors, which were originally used to manage blood sugar in diabetics, but they've also been shown to protect the heart, even in people without diabetes.
That's pretty amazing. Almost like unexpected heroes in the fight against heart disease.
You could say that. And sometimes a device called an implantable cardioverter defibrillator, or ICD, can be a true lifesaver.
I've heard of those, but I don't really know how they work.
Well, it's a small device implanted under the skin, usually near the collarbone.
Is it like a pacemaker?
They're similar in that they're both implanted, but they do different things. A pacemaker keeps the heart beating at a steady pace if it's too slow. An ICD is all about detecting and treating those life-threatening arrhythmias, like ventricular tachycardia, or VT, and ventricular fibrillation, or VF.
So it's always watching, waiting for trouble.
Precisely. If it detects a dangerous rhythm, it delivers a shock to the heart to get it back on track.
Like having a personal bodyguard for your heart.
Love that analogy. ICDs are often recommended for patients who have survived VT or VF, but there's no clear cause for it. Also used for patients with HOCM, ARVC, and inherited channelopathies, all things we talked about earlier.
So it's a safety net in
Yeah.
case something goes wrong.
Exactly. It's an amazing technology that saves so many lives. But let's switch gears a bit and talk about electrocardiograms, or ECGs. Recognizing those dangerous patterns is super important.
Ah, yes, ECGs. Those squiggly lines.
Those are the ones. ECGs record the heart's electrical activity, and certain patterns can tell doctors about serious problems that need attention, like right away. Let's look at some of these dangerous patterns.
That sounds like we're about to decode the heart's secret language.
That's a great way to put it. Let's start with hyperkalemia, which just means high potassium in the blood. Specific changes on the ECG tell us this is happening, and we can actually show you a visual of what that looks like. Hyperkalemia is super dangerous for the heart.
So the ECG can pick up a chemical imbalance.
Yep. And when it comes to potassium, that imbalance needs to be fixed ASC. There are a few ways to do that, like medications or even a dialysis, but the point is we got to act fast.
Time is of the essence.
You got it. Another key pattern to look for is one associated with HOCM. That's the hypertrophic obstructive cardiomyopathy we talked about earlier. Remember, that one causes the heart muscle to thicken. Well, it shows up on the ECG in specific ways, including deep, narrow Q waves, which some people call dagger Q waves because of their shape.
So specific patterns can point to specific conditions.
Exactly. And with HOCM, ICDs are often recommended to prevent sudden cardiac death.
It's amazing how much you can learn from these patterns. What other patterns should we be on the lookout for?
Well, there's one in a condition called pre-excitation syndrome. It's basically when you have an extra electrical pathway in the heart, kind of like a shortcut. This can lead to rapid heartbeats.
Like faulty wiring in a house, like a short circuit.
Perfect analogy. The ECG will show a short PR interval, a narrow QRS complex, and this thing called a delta wave. But the tricky thing is, some medications are actually dangerous for people with this. Things like adenosine, verapamil, diltiazem, digoxin. they can make the condition worse.
So it's not just about knowing the pattern, but understanding how to treat it, too.
Exactly. And even lifestyle choices matter. Reducing alcohol and caffeine intake is important because those can trigger arrhythmias. And in an ICU setting, you have to be extra careful with meds. Things like atropine, glycopyrrolate, and ketamine should be avoided, with propofol being a safer option for sedation.
Sounds like this condition needs to be managed really carefully.
Absolutely. And within pre-excitation syndrome, there are a couple of subtypes worth mentioning. WPDE syndrome is one where the extra pathway connects the atria and ventricles directly, causing that shortcut we talked about. Treatment for WPW might include medications like flecainide, amiodarone, or esmolol. These all work to slow down the electrical impulses in the heart.
So they're like traffic cops, keeping the heart's rhythm in check.
You got it. And then there's LGL syndrome, which is usually benign.
Wait, so not all pre-excitation syndromes are bad?
Right. In LGL syndrome, the extra pathway merges with the heart's normal conduction pathway, the bundle of His. This means those signals are still somewhere controlled. The ECG will show a short PR interval and a narrow QRS complex, but no delta wave. That's a key difference.
Those little details really matter.
They do. And while LGL syndrome often doesn't need treatment, in some cases, doctors might prescribe beta blockers or calcium channel blockers like verapamil or diltiazem. Those can help regulate the heart rate.
So many variations, it's amazing.
It is. It just shows you how complex the heart's electrical system really is. Another interesting one that shows up on the ECG is Brugada syndrome, this genetic disorder that causes abnormal electrical activity.
Okay, and what does that look like on the ECG?
Well, you'll see ST elevation in leads V1 to V3, very specific.
So specific.
Exactly. But remember, for a diagnosis of Brugada syndrome, you need both those ECG findings and certain clinical signs.
So it's not just about the ECG, but the whole picture.
Right. Now, for treatment, ICDs are often used to prevent sudden death. But research is ongoing to find good drug therapies. Some meds, like amiodarone, beta blockers, flecainide, and propafenone, haven't been shown to work very well. But other drugs, like quinidine, isoproterenol, and a class of drugs called PDE inhibitors, like celestazol, those are showing some promise.
Sounds like there's still a lot to learn about Brugada syndrome.
There is. Always more research to be done. Okay, let's move on to sodium channel blockade. This can be caused by certain meds or toxins, and it causes a very particular pattern on the ECG. You'll see a wide QRS complex and a dominant R wave in lead AVR.
I'm not gonna lie, that sounds pretty technical.
It is a bit, but the important thing is recognizing this pattern, because then we can get you the right treatment quickly.
What kind of treatment are we talking about here?
Usually it's about restoring the body's electrolyte balance and getting those toxins out. This might involve something called forced alkaline diuresis, which helps to flush the toxins through urine. Sometimes dialysis or hemoperfusion is needed.
So spotting that pattern on the ECG is like a call to action.
Absolutely. We have to act quickly to reverse it before it causes serious problems.
This is all really interesting. Are there any other ECG patterns we should be aware of?
Definitely. There's one for a condition called arrhythmogenic right ventricular dysplasia, or ARVD. This one, like some of the others we talked about, affects the right ventricle of the heart and can increase the risk of sudden cardiac death.
Another heart condition with a very complicated name.
I know. But the main idea is this. ARVD makes your heart more likely to have arrhythmias, those irregular heartbeats, which can be fatal.
So what can be done about ARVD?
Often it's a combination of things. Medications like flecainide, propafenone, sotalol, or amiodarone might be used to regulate the heart rhythm. ICDs can be implanted to protect against dangerous arrhythmias, and sometimes a procedure called catheter ablation is used to get rid of the abnormal heart tissue causing the arrhythmias.
So it's a multifaceted approach.
Exactly. It's all about finding the right combination of therapies to minimize the risk. We already discussed long QT syndrome, so I won't go into too much detail on that again. But I do want to mention something called a fragmented QRS, or FQRS. This is a special type of notching or splitting within the QRS complex on the ECG.
Another one of those subtle clues.
Precisely. And a fragmented QRS can be a sign of myocardial scarring, which means there's been some heart damage in the past. It's also a predictor of future arrhythmias.
So doctors are always on the lookout for this.
They are. And the good news is, FQRS is a pretty cost-effective marker. It can tell doctors a lot without needing expensive or invasive tests.
That's good to hear. What else do we have?
Well, how about a pattern with a very dramatic name, the shark fin appearance?
Okay, shark fin appearance. I'm intrigued. What makes it look like a shark fin?
Well, on the ECG, it has this really sharp, pointed wave, kind of like a fin.
I can see that.
But more than the visual, it's what it means clinically. This pattern shows up when there's a critical occlusion of a coronary artery.
So we're talking about a severe blockage.
Yes, in one of the arteries that supply blood to the heart. And the really amazing thing is, the specific leads on the ECG, where the shark fin appears, can actually pinpoint the area of the heart that's affected by the blockage.
So it's like a roadmap to the problem.
Exactly. And when we see this pattern, it's a sign that we need to act fast. Restoring blood flow to that area is critical.
A true emergency situation, though.
You could say that. It triggers a rapid response to figure out what's causing the blockage and get that blood flowing again as soon as possible.
Wow, these subtle ECG changes can be so powerful.
They are. And then we have another pattern that needs immediate attention. ST elevation in AVR.
ST elevation in AVR. Okay, what does that one mean?
This often points to a very serious problem, usually affecting either the left main coronary artery or the proximal left anterior descending artery.
Those sound like important ones.
They are, like major highways for blood flow to a large portion of the heart.
So when those are blocked, that's a big deal.
Huge deal. Seeing ST elevation in AVR is like a major red flag.
So it triggers a rapid response to open things up and restore blood flow.
You got it. And time is really of the essence.
This whole discussion about ECG patterns has been so fascinating. I can't believe how much information we can get from these electrical signals.
It really is remarkable, isn't it? But it's important to remember that these patterns aren't just abstract lines on a screen. They represent real situations, potentially life or death situations.
That's a good point. It's not just about the technology, it's about people.
Exactly. And speaking of which, let's shift gears a bit and talk about another crucial element of responding to sudden cardiac events. Bystander CPR.
Okay, CPR. I think everyone knows that's important, right?
Oh, fifely. CPR, which stands for cardiopulmonary resuscitation, can help keep blood flowing to the brain and other vital organs when the heart stops.
Most people know the basics, but how effective is CPR in real life?
Well, that's where bystander CPR comes in. When someone collapses from sudden cardiac arrest, those first few minutes are absolutely critical. The sooner CPR starts, the better their chances.
So it's about empowering everyday people to step in.
Exactly. If someone nearby can start CPR right away while waiting for the ambulance, that can make a huge difference. It's a really powerful concept, but it also brings up some interesting questions.
What kind of questions?
Well, what are your thoughts on training everyone in CPR? Do you think it's realistic? Could we get the whole population comfortable and confident enough to do it in an emergency? Is it just too idealistic?
Those are great questions. I mean, there's the practical side of teaching everyone, and then there's the mental side, getting people to actually do it under pressure.
Right. And think about the logistics. How do we even make training accessible to everyone? There's so many things to consider.
Lots of challenges, for sure, but I think it's a goal worth striving for.
I completely agree. Imagine if everyone knew CPR. It could save so many lives.
That's a powerful thought. It really shows how important awareness is.
Absolutely. We need to equip people with the knowledge and skills to help in these situations.
You mentioned earlier those first few minutes are crucial. What makes that time frame so important?
When the heart isn't pumping, the body isn't getting oxygen, and the brain is especially vulnerable. Permanent damage can happen quickly.
So it's a race against time.
Exactly. The sooner we get that blood flowing and oxygen back to the brain, the better the chances of survival.
That's where CPR comes in.
Right. CPR, even if it's done by someone without formal training, can help to keep blood circulating and get some oxygen to the body while waiting for help to arrive.
It's like a manual override for the heart.
I like that. And the research shows that it really can make a difference. Studies have shown that survival rates can actually double or even triple when someone receives bystander CPR right away.
Wow, that's amazing.
It really is. It makes you realize how empowering it is to know CPR.
It does. So let's say someone collapses, and you think it might be sudden cardiac arrest. What should you do?
First things first, call for help, 911 or your local emergency number. And then, if you know CPR, start chest compressions immediately.
What if you don't know CPR?
Even if you don't, still help. A lot of emergency operators can talk you through it over the phone. Something is always better than nothing.
That's good to know. It's empowering to know that you can still help, even without training.
Absolutely. And with more and more places having automated external defibrillators or AEDs, the chances of survival are even better.
AEDs, what are those?
An AED is a portable device that can analyze the heart's rhythm and deliver a shock, if needed, to get the heart back to a normal rhythm. They're actually pretty user-friendly, with voice prompts to guide you.
So you don't have to be a doctor to use one.
Not at all. They're popping up in public places everywhere now, like malls, airports, even schools.
That's great. Sounds like we're on the right track.
We are, but there's always more work to be done. We need to keep raising awareness, encouraging people to learn CPR, and advocating for greater access to AEDs.
Absolutely. When it comes to heart health, knowledge is power.
Well said. Speaking of knowledge, let's get back to those ECG patterns. We were discussing ERS, or early repolarization syndrome, before we got sidetracked with CPR.
Right. You said it's usually nothing to worry about, but sometimes can be a sign of something more serious. Can you explain a little more?
Of course. Remember when we talked about those red flags within the ERS pattern?
Yeah, you called it malignant ERP, right?
That's right. This is where those little details on the ECG really matter. Malignant ERP refers to some very specific characteristics of the J point, which is a point on the ECG waveform.
I'm picturing that squiggly line again.
Right. So when the J point shows elevation with slurring and notching, it can mean there's a higher risk of developing dangerous arrhythmias.
So it's like ERS, but more worrisome.
You could say that. And when malignant ERP is found, treatment options might include an implantable cardioverter defibrillator, or ICD, to prevent sudden cardiac death.
So even though ERS is often benign, it's good to be aware that there are more serious forms that need attention. It seems like having a doctor who really knows how to interpret these ECG patterns is super important.
You got it. And speaking of experts, I think it's a good time to give another shout out to the London HeartbeatsZ Academy.
Absolutely. They've been amazing in supporting this deep dive.
They really have. And for anyone who wants to learn more about heart health, definitely check out their website. They offer over 150 courses on all sorts of topics.
It's an amazing resource. And don't forget to follow them on social media too. Facebook, Instagram, Spotify, and YouTube. You don't want to miss their updates and future discussions.
Couldn't agree more. They're great at making information engaging and easy to understand. But getting back to malignant ERP, it really highlights how important those subtle details on an ECG can be.
Every detail matters when it comes to heart health.
Absolutely. And as we were discussing ERS, or early repolarization syndrome.
Right. Early repolarization syndrome.
Yeah.
You mentioned that it's usually not a big deal, but there are times when it could signal something more serious.
Exactly. And I remember we touched on those specific red flags that can pop up within the ERS pattern.
You called it malignant ERP, if I remember correctly.
Bingo. And this is where paying attention to those tiny details on the ECG becomes crucial. Malignant ERP has to do with some very specific features of the J point, which is a particular point on the ECG waveform.
Okay, I'm visualizing that squiggly line in my head.
Perfect. So when this J point shows elevation with slurring and notching, it can be a warning sign. It suggests a higher risk of developing those dangerous arrhythmias.
So it's like a more intense version of ERS, is that right?
You could think of it that way. And if we do find malignant ERP, treatment options might include an implantable cardioverter defibrillator, or ICD. That helps protect against sudden cardiac death.
So even though ERS is usually harmless, it's good to be aware of these less common but more serious forms. It sounds like having a doctor who really knows how to read those ECGs is essential.
Absolutely. Having that expertise in interpreting those subtle clues can make a world of difference. But it's not just about relying on doctors, it's also about individual awareness, about knowing your own body, your own family history.
That's so true. We all have a role to play in protecting our own heart health.
Exactly. And that's something we're going to dive deeper into as we continue our discussion. We'll be exploring some surprising risk factors, as well as some really cutting-edge research that's leading to new and innovative treatments.
This is all so fascinating. I'm really looking forward to hearing more.
Great. Well, then let's get right back into it. Now, where were we? Ah, yes. Those subtle details on the ECG and how they can sometimes reveal some hidden risks.
I'm ready to learn more.
All right. Let's talk about Wellens syndrome. This one is named after the doctors who first described it, and it's characterized by some very specific changes in the T waves on the ECG. We usually see what we call deeply inverted or biphasic T waves in leads V2 and V3.
Okay, I'm going to be honest, I need a bit of a translation there. What does that mean in plain English?
Sure. So the ECG, remember, it's basically a graph of your heart's electrical activity. The T wave is one specific part of that graph, and its shape can tell us a lot. With Welland syndrome, the T wave looks kind of unusual, like a dip instead of a peak.
So like a red flag.
Exactly. It strongly suggests that there's a critical narrowing, what we call stenosis, in the left anterior descending coronary artery, or LAD for short.
And the LAD is one of the main arteries of the heart, right?
Sure. That's right. It supplies blood to a big chunk of the left ventricle, which is the main pumping chamber. So a blockage in the LAD is a big problem.
So what does it mean for someone if they have this Welland syndrome pattern on their ECG?
Well, it means they're at a very high risk, like really high risk, of having a major heart attack, and often within days or weeks. The tricky thing about Welland syndrome is people might have had chest pain in the past, but they might not have any pain when the ECG is taken.
So they could feel fine, but the ECG is showing a serious problem.
Exactly. And sometimes, to make it even more confusing, their cardiac enzyme levels, which show us if there's heart damage, might be normal or just a little bit high.
So it's like a silent threat almost.
In a way, yeah. And that's why being able to spot this pattern on the ECG is so important. It lets doctors intervene before a big heart attack happens.
What kind of interventions are we talking about?
Well, first of all, stress testing is a big no-no for Welland syndrome.
What do you mean by that?
Well, a stress test purposely puts stress on the heart. And for someone with this condition, that stress could actually trigger a heart attack. Too risky.
Okay, so what are the options then?
Since Welland syndrome often doesn't respond well to just medication, most patients need those invasive procedures like angioplasty or stenting to open up that blocked artery.
So it's a situation where you really have to act quickly.
Absolutely. And another one that needs quick action, similar to Welling syndrome in that way, is a pattern called the winter T waves.
Ooh, winter T waves. Okay, I'm all ears.
This pattern shows up as a particular type of ST segment depression and tall, peaked T waves, specifically in the precordial leads of the ECG. I know, it's a lot of technical jargon, but what you need to know is this pattern is very strongly associated with an acute occlusion, meaning a total blockage of the LAD coronary artery.
Another one of those red alert situations then.
You got it. It means we need to start reperfusion therapy right away. That means getting blood flow back to that part of the heart as quickly as possible.
It's pretty remarkable how much we can learn from these different ECG patterns.
It really is like a window into what's happening in the heart. And it's important to remember, these patterns aren't just lines on a piece of paper. They represent real-life events, serious events.
It's a good reminder.
It is. And to wrap up our discussion on these key ECG patterns, let's touch on one that's a little less straightforward. Early repolarization syndrome, or ERS.
Early repolarization syndrome. What's the deal with that one?
Well, this pattern is actually pretty common. We see it a lot in healthy people, especially athletes. But we also find it in people who use cocaine, and those with certain heart conditions like HOCM or hypertrophy of the interventricular septum, which is that wall separating the heart's ventricles.
So it can be a normal finding, but it can also be a sign of a problem.
You got it. And that's what makes it a bit tricky. Most of the time, ERS is totally benign, no harm, no treatment needed. But sometimes it can be linked to a higher risk of sudden cardiac death.
So how do you know if ERS is something to be worried about?
There are certain clues within the ERS pattern itself. We look for what's called malignant ERP, and that has to do with specific features of the J point, which is a point on the ECG waveform.
Okay, so we're back to the squiggly lines.
Right. So if the J point shows elevation with slurring and notching, that can be a red flag. It means there's a greater chance of developing dangerous arrhythmias.
Like a more worrisome type of ERS.
That's a good way to think about it. And if we do find malignant ERP, an implantable cardioverter defibrillator, or ICD, might be recommended to prevent sudden death.
So even though ERS is often harmless, it's important to know about these more serious types that need intervention.
Absolutely. It really highlights how important it is to have a healthcare provider who can properly interpret all these ECG patterns and figure out what's going on.
Right, someone who knows what those subtle clues.
Those small details on an ECG can be so important.
It really is amazing how much we can learn from those patterns.
It is, and it's a reminder that when it comes to heart health, every detail matters.
Couldn't agree more.
So let's continue exploring, shall we? Right, those tiny details. They can be so easy to miss, but so crucial.
It really is a delicate balance, isn't it? Trying to find those subtle signs without overreacting to every little thing.
Exactly. It's all about having a good understanding of what's normal and what's not. And that's where knowledge and awareness come in.
Absolutely. And to wrap things up, we've covered so much ground today in our deep dive into sudden cardiac death. We've talked about the causes, the warning signs, the importance of ECGs, and of course, the power of bystander CPR.
It's been a really comprehensive discussion, and I hope it's empowered our listeners to feel more knowledgeable and proactive about their own heart health.
Absolutely. Knowledge is power, and when it comes to heart health, that knowledge can truly be life-saving.
I couldn't agree more.
So on that note, I want to extend a huge thank you to our expert for joining us today and sharing your expertise. It's been an absolute pleasure learning from you.
The pleasure's been all mine. It's always rewarding to talk about such an important topic.
And to all our listeners out there, thank you for tuning in to The Deep Dive. We hope you found this episode informative and empowering. Remember, taking care of your heart is one of the most important things you can do for yourself.
Absolutely. Stay curious, stay informed, and most importantly, stay heart healthy.